this is about how can we help family carers? And to be honest, it's about how can you help any family carer, not necessarily for MND, but because we're all involved in MND, and I've been for a long time involved with the MND community. We thought we'd bring this program at the national level and you know, see how we go with, you know, see how we can move it forward, basically. So the key learnings, the health professionals will acquire knowledge and skills to identify key areas where family carers require support, allow space for family carers to identify their separate support needs as distinct from those of patients, and provide an opportunity to focus on family carer priorities. Facilitate delivery of carer-identified support likely to improve carer outcomes, with the potential to enable targeting of resources in a more effective manner. Recognize the benefits of family carer support, not only to the family carer, but also to the care recipients, the health professionals, and their organizations. So I don't need to tell you how much studies there are on family carers in general. They play a vital role in the care of a person at home. They are providers of care, but they also have their own needs, and identifying their own support needs is important. There is a need for a straightforward assessment tool suitable for everyday practice. And in most developed countries, there are so many health policy recommendations that recognize the impact of caregiving and stress the need to support carers. So we do have a lot of Carers Act, carer policies, and probably every few years we have a new one come in. So my involvement in this field came at the start of my involvement with palliative care in general. And we were commissioned to do this study by Palliative Care Australia, the hardest thing we have ever done. And I must say, I read so many submissions from family carers, and those that came from MND family carers really hit me hard in terms of how much they're struggling to gain support. So, and all the reports, newsletters, everything I've read had all negative titles, like caring enough to be poor, ignored and invisible, caregiving as a risk factor for mortality, warning, caring is a health hazard, missed opportunities, family caregivers and leisure, an oxymoron, and our own study, Palliative Care for Families, Remembering the Hidden Patients, at the time of that era when, you know, we were looking at this. So, and all the other reports that came after this have one way of negative connotation when they talk about family carers. So family carers of people with MND often describe their caring experiences as unrelenting due to the progressive nature of the disease and the hopelessness of recovery compared to cancer. And we've done so many interviews over so many studies, and they invariably bring in, we wish we had cancer. At least there is something that's happening in the field, whether treatment or, you know, clinical trial or some initiative. But, you know, with us, with motor neuron disease, we don't have anything to basically hope for. So one MND advisor was really good at describing why we need this. I think it's interesting to see how carer needs change over time. And then their needs don't always follow the same trajectory as the person with MND. Sometimes what I perceive as a very stressful time for the carer, they seem to sail through, whereas something minor for me at another time can unleash a great emotional tide for the carer. So that really sort of emphasized that we really need to ask the carers themselves where they are in their caregiving journey, because as from this quote, and I'm sure you felt the same yourselves, you can't just, you know, think yourself where they are in their journey. So let's explore a little bit your current practice. How do you currently become aware of carer support needs? This is just a bit of a discussion so that we have a feel of, there we go, I'm back again, I can see you. So anybody would like to just, you know, tell us about how do you actually become aware of carer support needs, or, you know, how often do you find yourself asking a carer, how are you? Yep. Boardroom essay, or have we got a hand raised?
So for me, it would be during a client visit, phone calls, text messages. I get emails from them. I get emails from extended family, and even from other allied health. Our in-house allied health team will let me know what's going on.
Yeah. Is that Kerry? Sorry, I'm just trying to see.
Oh, it's Leanne.
Leanne.
Yeah.
Leanne. Okay, right. Okay. Yeah. Any other?
Yes, it's Lily
yeah.
here
Yeah.
Queensland. Yes, well, me particularly, we do some preclinic screening before patients visit. So I call the patient and the carer, and then that's when they sometimes raise the issue with me. And also I get emails and phone calls from them to raise their concern.
Yeah, great. Any other contribution to the discussion? I can't see any hands raised, so we keep. So how much do you rely on picking up cues? You're able to work out, Justine?
I think what I've noticed with this particular client group is even when you directly ask them, how are you looking after yourself? What can I do to support you? There's just such a focus on supporting the other individual living with MND that even when you acknowledge it, you address it, they acknowledge it, they still put it back on the back runner. So I think the cues are definitely important, but even when the cues have been acknowledged and addressed, it still can go as an unmet need because the person doesn't have capacity or isn't able to, for whatever reason at that point, look at their own needs.
Yeah, perfect. That's exactly the situation. And they don't want to take the time, your time, to look at their own needs when the patient is so desperate, to be helped. And also, do they know what their needs are? So they are in such a muddle about, so many things that are happening that they're not able to focus on what they actually need help themselves. And that's why having a systematic way of delineating those support needs has been really useful for the carers. So I'll share this with you as we go through the presentation. Yeah, okay, so I'll go back to the presentation. No, I didn't go back to the presentation. Here we go. Can you see this one? Jennifer?
Yep, we can.
Yeah, good. Okay, good. So, and that's exactly why we, people like me, researchers like me for the last 20 years, we were trying to find a tool that actually, put family carers at the front foot. What is it that you need so that you can help look after your loved one, but also look after yourself. One of them is the Carers Alert Thermometer. It's an evidence-based tool designed to identify and support the needs of unpaid caregiver of people with palliative or progressive conditions. So it started with, in the palliative care field. The research underpinning this tool was informed by carers and practitioners. The CAT presents a useful assessment tool for physical, practical, social, financial, psychological, and spiritual support needs. I believe you all have the hard copy. You received the hard copy or the electronic copy, so I'll walk you through that. It has 11 questions. It begins with a general question about any current needs, followed by 9 support need indicator questions across 2 domains. So the general question is about, do you currently have any needs or concerns about providing care or your own health and well-being? Now, I can assure you, they're all going to say no, or mostly no. That's what they do, because they don't want to focus on themselves. But you keep going with the questions, and you will see how things start unfolding. The next 9 questions are into 2 categories. The first one is about the current caring situations, which means what do you need help with to look after your loved one? And the second one is about their own health and well-being. So these questions have a traffic light scoring system So carers can rate their support needs as green, which means low, amber, medium, or red high, indicating the level of need and potential risk each alert poses to the caregiving situation. Now, we've used in the past other short assessments like this one, but they didn't have a scoring system. So the health professionals said, well, how do we know which carer we need to support first? We know they all have needs, but we don't have an indication about who we're going to see in the next 2 weeks, in the next 2 months, or in the next 6 months. Hence why this answered, those questions that they wanted to know about. It has also a question on end-of-life preference, and that is so important, particularly for people with MND, because it's really a death sentence from the start, the diagnosis. And a lot of also our clients here in WA say, well, we have, our service providers come to us and no one mentions to us, would you like to talk about end-of-life preferences? And I guess there's been quite a lot of talk about this in the last 2-3 years, because the health departments everywhere really want people to have, advanced care planning. And I guess I had the amazing opportunity last year, being the West Australian of the Year, and everybody knew I was talking about how do we skill everybody in terms of death, dying, grief, and loss. And part of the conversation was, well, do you know your values? Do you know your preferences? Do you know what are the choices that you can have? So I'm hoping I've made a dent into people's awareness that they need to discuss this. The other item that the CAT has is resilience to continue to provide care. And that's really important because it gives you, in a way, that thermometer sort of bar where they are in terms of, again, in their caregiving journey. Then there is a space to create a collaborative action plan for the priority needs that the carers have raised in terms of the conversation that you've had with them. So it's not about you telling them what they need, it's about you kind of facilitating that conversation process so that they can decide where they need help. And then the review date is when you think this is needed, or they may tell you, okay, let's see, I'd like to see you in another month or so. And you'll see from the video, the role play that we had, how this played out basically. So if you have this in front of you, so the first one is, do you currently have any needs or concerns about providing care or your own health and well-being? Yes, no, unsure. Quite a bit would say no and unsure, but you keep going. How much support do you need? And that's now item 2, with any information about the person's condition and how their care needs might change over time. So this is where you tick. If they say yes, quite a bit, not a lot, medium, high, you just tick basically. Or they can do it themselves. You don't have to be with them if they are happy to do it themselves. And they just hand it over to you if they've done all the, deciding themselves. And then this is where you come and discuss the action plan. Number 3, to provide any of the personal care or general daily care. 4, to provide any emotional or spiritual care the person may need. 5, to know who to call in emergency or out of hour to discuss any concerns about the person. 6, to feel involved in the decision making and listened to by professionals about the care needed by the person. So that's the current caring situation. The next 4 are about the carer health and well-being. About financial, legal, and work issues. These have come up quite a lot. To take a break from caring during the night or overnight. To balance your own needs with the demands of caring. To manage any feelings or worries that you may have. Feelings and worries have always come at the top, whether we've done this in the UK or Canada or here in Australia. The next question is about, and I would say if appropriate, include, do you know the person's wishes and preferences for end-of-life care? And that could be yes, no, or unsure. Number 11, how able do you feel you can continue providing care at the current level for the person with MND? So it goes from not very able, 1, to very able, 5. The next page of that is make a plan together. So you highlight with them, you may find that they've put in quite a few of the items medium or high, and you don't have in one visit time to basically go through all of their needs. But what you could say in this visit, how about we focus on the 3 priorities that you'd like to discuss, and I could facilitate, you know, finding help for you, or you could tell me what you want. And that's why you put the priority need, whether it's number 3 or 5 or 6, in the left-hand side of the table, and then you write the actions identified for the 3 priorities. Then you have the next review. You agree on a time, and that's about it. It's something that doesn't take long, but then you have a record of, in your initial visit, these are the needs that they wanted, and then when you visit again, you'd see how the caregiving, you know, landscape had changed for them and what else they will need. Now, when we did the pilot in WA, our MND advisors thought it's quite a busy form, that one, and they wanted something with like sort of warmer colors and pastel colors. So it's exactly the same content, but we've just taken the thermometer because it was like too much to have all that in one. So, but it's, you know, up to you, whichever one you use the same, they both basically collect the same information. So it is a structured, flexible, and comprehensive and tailored approach. It identifies key areas that the family carers say they wish support in. It has broad support domains. So you really need to look at it. It's not a checklist. It's not a tick, tick, tick. It's a conversation opener, basically. And the carers identify their priorities, decide what the issue of concern is, and decide what they feel would help them. So one carer said at the onset, you have no idea. So many new terms. I mean, onset, I suppose, when the diagnosis has started and all these medical jargon that comes to them and all that. So you are so caught up in the diagnosis that you are not thinking ahead. Completing the CAT prompted me to find and seek relevant information much earlier. So it is a 5-stage process. There's the introduction of the CAT. The carer reflects on their needs. Then there is the assessment conversation, then the shared action plan, and then the shared review. So what would some of the carers say, you know, at the start? So how and when could you first introduce the CAT to a carer? Best when introduced early, may reduce need for crisis management. And this is what we want to get to. We don't want them to reach crisis management and then they need mental health support or all sorts of things. So that would really alleviate this part of thing. Opportunity for carer to think about their own needs and not an obligation to fill in a form. So the key message is to tell the carer when you're introducing it, this is the start of an assessment process. It's about their own individual needs at the moment, not the needs of the person they care for, but the needs of the person care for are still important and you are still looking after them. So it's not an either or situation. The aim is to support the carer in the caregiving role, to enable them to care and receive the support for themselves. The CAT questions are something for carer to consider. These are the types of support other carers have needed. Because sometimes they want to say, they are very altruistic, so they will want to do it, but it's really good for them to know that it has come from a range of focus groups, interviews that family carers have actually said, these are the domains that we need help in. Stage 2 is the carer reflecting on their needs. How will you ensure that the carer has space and time to consider what their own needs are? So allowing time for the carer to consider their needs. They really need their own separate need. We can't keep, well, I'm not generalizing here, but you know, we always hear, and the interviews have showed this, they follow you on the driveway conversations, or at your car, basically to just tell you something about themselves, because they don't want to take time from the visit to the patient. So they really need to know that they matter, and you know, they can have their own time as well. Arrange time for follow-up assessment conversation, ideally when giving the CAT form to the carer. So the key message is encourage carer to take time to think about their needs using the CAT form as a prompt and during a quiet moment. Encourage the carer to discuss their needs with the person they are caring for, or with family members or friends, guided by the cat. So, you know, unfortunately, what I hear from our families here in WA, their friends and their families don't know enough about MND to help them, or they're too scared, or they want to, you know, they want to ask to you know, to be helpful, and this is not happening. And again, the dynamics between the person they are caring for and themselves is not really working either. The assessment conversation. How would you be able to complete this conversation? Identify which support needs are most pressing for the carer at this moment in time. So their top 3 priorities for that conversation when you are with them. Identify what the carer feels would help them in relation to these support needs. They really, this is encouraging them and empowering them to actually look at self-help methods. It's not about always finding a paid service for them. Identify sources of support the carer may already have access to: family, friends, support agencies. This is so important, and this is at the core of compassionate communities, which we are also promoting at the national level now with starting Compassionate Communities Australia, is that families and friends are there all the time for these people. And they need to basically bring them in and involve them in their life, because invariably people want to help, but they don't know how. And this is where knowing more about the disease and the plight of their the family would really helpful for the family. Identify sources of support the carer needs assistance to access, so referring the carer to available services. So it's really more about what are the informal networks that are able to help, and then after this, what are the formal networks that can help them. Identify support needs may not be possible for sometimes at the short term, and you know that's fine. You could tell them, for instance, if they need a appointment with a counsellor, it may take 3 weeks to find, you know, that time for them, and they're fine. They understand that. So it's important not to make assumptions about the kind of support a carer needs, or to try and jump in and fix things on their behalf. Take a step back and allow the carer to take the lead. And that's what I'm saying. It's about empowering them to help themselves. So the shared action plan. Will you be able to produce a short action plan following this assessment conversation? This is a shared activity between the carer and the health professional. I mean, I know when we did the trial with Silver Chain in Perth, we had a randomized control trial. That's something that we really need to teach the nurses. Don't start by saying, in Silver Chain, we have X, Y, Z that can help you. Let them talk about it themselves first, without showing them first what are the available resources that you have for them. That can be, you know, talked about a bit later on. Summarize the outcome of the assessment conversation and document the action plan, including actions the carer plans to take for themselves. That is the first thing. Actions the health professional will take, referral to a service, for instance, plans for review of the assessment, and any support needs resolved as part of the assessment conversation. And this is where it's really will be very rewarding for you, because when you come back and do it, say, after a few months, you could see how some of these needs have been resolved, but of course, there are going to be other needs that will come up all the time. So the shared review, when do you review the whole process? Review the carer support needs is likely to be ongoing. If the carer's circumstances changed, a full reassessment of the support needs is beneficial. Reviews can be initiated by the carer or health professional. And this is what we're trying to do through this program, is just get the carer to initiate that, instead of relying on you as health professionals to always ask them, where is your need? Let's discuss it. And hopefully that will go on your website as the separate MND associations, and also on the MindOz platform. The MindOz, I'm sure you've all heard about it by now. There's been a lot of training for all the MND associations. It's like the MND register, but it is in the name of the health patient now. We're having a meeting with the MindOz group soon to see how we can introduce, have a carer register, or somehow link it into the patient register. So as a summary, the carer can complete this by themselves, but sometimes they will need your help. They will score the support needs on this 4-point scale, and they have professionals to complete the actions identified for the 3 priorities for that particular visit. So in WA, this is we had 30 take part in the pilot study. The blue one is the first contact they've had, and the orange is the follow-up. So as you can see with the blue one, the managing feelings and worries came at the top, providing emotional and spiritual care came after that, and information about the person's condition and how that may change over time. But if you look at the follow-up, these things have been resolved. So not as many have asked again for looking after them. I mean, they're still there, but it means that the assessment conversation you've had with them has actually hit the mark in terms of they're not asking for the same thing again at the follow-up to the same extent. However, the information about the person's condition, the orange bar has gone up more at follow-up, again, because these people are deteriorating and therefore they need, again, more information about where they're at with that. So just to give you an idea how the results basically shape up on sort of the bigger picture. This is at the time they were bereaved. And we've done that, again, this is part of the trial we did with Silver Chain here. And the control group are the ones in dark and the intervention, the lighter gray. So when we've asked the control and the intervention at the bereavement stage, where are your needs, where you're sitting with them, you could see the control group have got higher needs than the intervention group in nearly every single of those items of the CAT or that the assessment, this particular assessment tool we used then. So having time for yourself in the day, the control had, a lot more needs because they haven't had to prepare for that during the caregiving experience like the intervention group had, who have used that assessment tool. Again, the highest needs were understanding your relative illness, where we've got the star, and also knowing who to contact if you are concerned. The only 2 areas where the intervention looked like they need more need is about practical help in the home and looking after your own health, which is interesting. And we think it's about they know that they can ask for help. We've given them the permission to ask for help. This is what we heard from them through this process. And we legitimize their needs, so they feel they can ask for it now, basically. So that's great. It's a great, outcome out of this study. But that affects the bereavement experience. This is why I'm showing you this. So if you do all this assessment during the caregiving experience, their bereavement outcomes will be much better than somebody who haven't gone through that. So examples of carer needs. What would they need in terms of understanding your relative's illness, explanation about the disease and its likely effects on the patient, knowing what symptoms to expect, and being given a full explanation of the stage of the illness when requested. They don't want everything all in one go. It really makes them feel too overburdened. But but if you keep that conversation with them, they will ask as time goes where they want more information. Providing personal care, daily care and equipment, getting additional help to manage some of the patient's personal care needs, learning skills, for instance, turning techniques, being involved in hands-on care provision, practical help at home, knowing about what equipment is available and how to obtain it, understanding how to use the equipment provided. Examples in terms of what emotional spiritual care they want, have the opportunity to express what's meaningful to the carer and to the patient, being able to take part in meaningful activities, people taking into account beliefs that are important to the patient and the carer, know who to call in emergency after hours. They want to talk to a person. They don't want a number, just a number to contact. And unfortunately, everything is going now towards apps and hotlines and things like this. But please remember, they still want a person to talk to by the end of the day. Being able to make contact anytime, day or night, having an individual who understands your concerns, accessing help with symptom management out of hours. And that's always been a challenge, the out of hours service provision. Financial, legal, work issues, juggling carer with work and other commitments, understanding entitlements to benefits, and obtaining assistance with application forms. This is where our service providers in WA struggled the most. And this is where we have now got on our website the toolkit that would basically have links to resources where they can be signposted, whether the service provider attracts the attention of the carer or the carers can be pointed to use that toolkit, which I'll tell you more about as we get there. Taking break from caring, having time for yourself in the day, feeling okay about being away from the patient, being able to do something normal for a short time by accessing support from family, friends, information on support available for short respite services which do not necessitate the patient being away from home, involving other families and friends. So these are some of the conversation topics that may come up in the conversations. Balance your own needs with the demands of caring, being aware of the impact of caring on your own health. I still recall when we did this study with people who are looking after people with dementia, and the immediate response of family carers, yes, I know how to look after myself. I need to put my husband in a nursing home because I can't really deal with this. But yeah, it was like it sort of made them, they decided straight away, what is it that they're going, to give them that relief that they've been, struggling with all their caregiving experience. Needing permission to consider your own health, feeling okay about asking for help. And I think this is what we've lost from Western culture. People just don't want to ask for help, or we've lost the skills of asking for help, which means if we don't do that, we're shutting all the social networks around us that are able to help us. And in the compassionate communities movement, the first thing we tell people, it's okay to ask for help. And one of the family carers, a lot of people came and asked him, how can we help you? And it was, during the around the time the funeral, and he kept saying no, no, no. And then 2 weeks later, he needed the help, but of course nobody was coming forth because they thought, he shut the door basically. What we said, you could have said, not now, but could you please call on me in 2 weeks' time, please? So leave the door open. People want to help. Feeling comfortable about accepting help, and that goes again with asking for help and accepting it. Accessing help for household tasks from different sources like friends or family, letting others know what would help you. And that's so important, is they need to know how to ask for help, but what is it they can help with. And what we've done again and there's a lot of interest in it, is the Compassionate Connectors project, whereby there is a kind of rostering of the caring helpers for those families that are under the care of the compassionate connector, because then families have highlighted where they need help, and people have come and helped them, and the connector sorted the roster for them. Manage feelings and worries, feeling okay, talking about how you are, knowing who is around to discuss emotional support needs, having someone to talk to. And again, we felt that our service providers struggled with this, and we've 2 years ago we've sought the services of a grief counselor who is part of the team, whereby if an MND advisor is not able to deal with those feelings and worries, they get referred to the grief counselor. And also we had bereavement support groups online, whereby our family carers were able to again talk about all these with the facilitation of an expert in the field. End of life wishes and preferences, discussing wills, advanced health directives, being able to talk openly about dying and funerals. And again, hopefully we've made a difference in terms of breaking those taboos and stigmas. It's okay to talk about death, dying, grief, and loss. One of the sort of catchphrases I use, it won't kill you to talk about death. Or we only die once, so let's make it a good one. Understanding the dying process, recognition when someone is close to death, knowing what to do and who to contact when someone dies. All these things, they really need to talk about it much earlier than the last 2 weeks of their life when we know that the patient is about to die. I found this on somewhere internet. what is the carer's bingo? In terms of administration, sitting on hold with an insurance provider, organizing medications, memorizing your loved one's medical history, driving over an hour for a medical appointment, making a folder of healthcare information, empathy, feeling heartbreak as your loved one declines, feeling burnt out by caregiving, feeling relief thinking about your loved one's death, feeling resentful of others who can't and won't help, feeling guilty for needing a break. Workplace, balancing caregiving with a job, asking for time off work to take care of your loved ones, zooming out at work because you're exhausted, losing sleep because of financial worries, grief, grieving who your loved one used to be, grieving how your person's death was supposed to be, grieving your life before becoming a caregiver, grieving the dreams you had to put on hold, anticipating the grief you'll feel in the future. Social, losing friendships because of caregiving, feeling disconnected from your hobbies, postponing relationships because you have no time or energy, struggling to explain your life to non-caregivers, declining important invitations because of caregiving. That is exactly what comes in all the interviews, and I was so happy to see it put like this in one document. So what did the family carers say about taking part in the pilot? I can see that in 5 years' time, when it's an established tool and part of the process, this will be a good thing. Was amazing, really. Didn't realize it would solve all of my problems. It helped me identify what was wrong in my life and how to support myself. Brilliant outcomes using this tool. Helped to point out what I needed to do in order to help myself, helped me get clarity, calm, peace. This really hit the mark in helping me address my needs and clarify actions. I think it's a brilliant idea. It's something that should be repeated regularly and would have helped alleviate or prevent some of the issues we faced. It also enabled the advisor to highlight to my husband so that he got a better idea of how I was feeling and what I was going through. If we had this earlier, it might have stopped us getting to the point we got to. Now, in the many studies, this is exactly what the carers have said, whether it's MND, dementia, cancer, name it. The problem is how do we get the service providers to actually use it on a regular basis? So when we did the national survey for bereavement support for bereaved MND family carers, we asked them, who actually helped you in your bereavement experience? As you can see, family, friends, funeral providers came quite high. So they're the informal people in our community. So that's quite clear how compassionate communities is really kicking well in our community. People are helping the person in need. Then you've got the GP. Then you've got the MND associations. They were rated really high, even during the bereavement experience. So obviously those rapport that they have with you during the caregiving experience carries on during the bereavement experience. They don't want to let go of that wonderful rapport they've had with their MND associations. And that's something really good, I think. It's really a strong relationships, which means you've done a great job with them during the caregiving experience, so therefore they want to keep having that rapport with you. So I'll just play now the video that the developers of the tool, the lady in the stripy shirt, that's Professor Mary O'Brien, and Dr. Kate Knighting is on the other side. And one of them is the care advisor, and one of them is the family carer.
As part of the video, we'll show excerpts from a role play of completing a cat by 2 members of the cat team. It will provide an example of how you could introduce the cat, start the questions and support the carer to choose a rating, and how to identify the priorities for the plan. The actual next steps chosen will depend on the role of the person who is the assessor and also the available resources and services. Whilst there are key topics to include in the questions of any CAT completion, using language which is familiar to the carer and the assessor is key to ensuring good communication. So please use them as a guide and not feel that they need to be spoken verbatim. The scenario is about Mildred, who has been caring for George, who was diagnosed with motor neurone disease 18 months ago after developing weaknesses in his left leg. His condition is gradually deteriorating, and Mildred is worried about how quickly this is happening. She's devoted to George and has been caring for him alone over the past year, without a break or any support, although 2 grown-up children and friends have offered to help. Mildred is embarrassed to ask for help and scared that George will be forced to go into care if it looks like she isn't coping. She is expecting the MND advisor to visit her soon and to discuss her needs, but isn't sure how useful it's going to be.
Okay. Thank you for seeing me today, Mildred. So we've finished the visit with George, and as I explained to you on my last visit, we're using this care as a thermometer to just look at any needs that you might have in terms of your caring role for George or in terms of yourself. So we filled in the top of the form. Okay. So we're just going to go through these questions, which are about different topics, and we're going to circle the level of need that you feel that you have for each of these, okay? So we're going to start off with a general question about whether you currently have any needs or concerns about providing care or for your own health and well-being.
No, I think everything's fine. Yeah, we're managing, we're coping.
Right, okay. And you've been sort of caring for George for around 12 months now.
Yeah. He got his diagnosis about 18 months ago, and then I'd say over the last year he's needed some help.
Right, okay. So, and you're feeling at the moment that there's no particular needs or concerns?
No, I don't think so. I think I think we're managing.
Right. Okay, so I'll circle that then. Okay, but we're still going to go through the questions just to look to see if anything does come up for you. Okay. Okay, so do you need any support with information about George's condition and how his care needs might change over time?
Well, to be quite honest, I don't really know how his needs are going to change.
Right.
I don't really know how the illness is going to progress. It's certainly progressing quite quickly so far. He started off with weakness in one leg, and now both legs are weak, and his left arm is weak as well. But we don't talk about it. George doesn't want to talk about it, and I don't really want to find out too much, I don't think. Right. I don't want to know how what's going to happen, but I suppose maybe I might need to.
Mm-hmm. Yeah, absolutely.
Yeah.
And I think being cautious about knowing too much too soon, I think that's quite normal, and it can be scary, can't it? Yeah,
it is. And as I say, George just doesn't want to know what's going to happen. Well, at least I don't think he wants to know.
Okay.
But we don't talk about it.
Okay.
So I don't really know what his thoughts are. I know it's going to get worse, but I really just I don't know how quickly or what's going to happen next. I know that he has, he's been slurring his speech a little bit. And he's been coughing when he's eating sometimes, but I don't know whether that's just him eating things too quickly. I don't know whether that's the MND.
Okay.
I just don't know.
So it sounds like you're feeling that you might need some more information about what's coming, but that you want to take that steadily in terms of learning more, but at a gradual pace.
Yes.
Alongside how things are going. So,
But where would I get this information from?
well, I think that we have sources of information that can support that, and I can also signpost you to other sources. We can look at the other professionals that are involved in George's care and how they may support those information needs for yourself and for George.
Okay.
So
They won't tell me everything though, will they? Not in one go.
I think if it's clear that you want to go steadily and understand things bit by bit as you go along, that people will respect that and give you the information that you need at this time to help you understand what's happening and maybe see what might be next, so that it's not too overwhelming. So we can look at that when we come to make a plan around here. And so in terms of the rating on here, would you say that needing information to understand the future and what might change, would you say that was a low, medium or a high need for you at this point?
I think it might be a medium.
Okay.
Simply because of these new changes that I've been seeing, and I'm not sure whether they're MND related or I think they're pretty old, but I'm probably trying to convince myself that they're not.
Well, we can definitely have a talk about this afterwards in more depth. So we'll go through the questions and then make a plan about what's needed, and then we can have a proper chat about some of that information, where that is, and what can support you with that.
Thank you.
Okay. So thinking about yourself and your own health and well-being, do you need any support around being able to have a break from caring? Whether that was a break during the day or overnight? Does this ever happen?
I don't have any breaks. I look after George 24 hours a day, 7 days a week. I'm here for him.
Okay.
I can't leave him. I left him once, and when I came back, he'd slipped out of the chair, and I felt so guilty. He could have really hurt himself. So I can't leave him. I can't leave him at all.
Okay, I can see that you're feeling a lot of responsibility there because you care about him.
I felt so guilty, really guilty that I'd gone out to the shops for something. I can't even remember what it was now.
Okay.
And I can't leave him.
Okay, so you're feeling that he can't be left. So perhaps there's a need to look there at whether or not we can provide any support there, or find support locally, maybe friends and family. How is that for you? Is there any opportunity for friends and family to offer any support for you?
Well, we've got lots of friends who keep asking if there's anything they can do, but I just keep telling them that we're fine, that we can manage, because I don't want to. I don't want people to think that I can't cope. I can't look after my husband. Same with my children. I have 2 children, and they live nearby, and they keep asking what they can do for their dad. But again, I just think it's my responsibility in sickness and in health. I have to do it. But
I understand.
I do wonder how long I can do it for.
Yeah. I think that was my thought as well, because 24/7 is a lot, isn't it? And you need time for your own health and well-being and friendships and family as well. So perhaps there's a chance that we could have a look at that and see what might be possible, because having support doesn't take away all of the love and care that you provide to George, and it's important to look after you too, isn't it? So it sounds to me then like there's quite a need there maybe to look at that with you as to what could be available.
Yeah.
Do you think that we might go somewhere medium or high on that? How are you feeling about needing a break?
Well, I am feeling as if I'm getting close to the point of been burnt out. So I think it's probably something that I really do need to look at. So it's probably a high need.
Yeah, I think so too. I think that's a high need for us to look at in terms of what's possible, because if we don't look after you, then you will find it harder perhaps to look after George, and if that, you don't want that to change, then we
I
need
don't
to
want
look
him to have to go into care.
No.
So yeah.
Okay. So it may feel like it's too soon, and I don't want you to think that we're just thinking about end of life here, but do you know what George's wishes are for care in the future, or whether he has any particular end of life wishes?
I don't know what his thoughts are.
Okay.
And I find it very hard to raise it with him. We're plodding along day by day at the moment, and I think because he's experiencing some other issues with his speech and with the coughing at meal times, I just don't think I could talk to him about things getting worse.
Yeah.
I think he's finding it difficult to cope with what's happening at the moment.
Sure.
Never mind thinking about what could happen in the future. And he's never been one for talking about illness or death.
Sure. Okay, well, I mark that as no, that's not known currently, and that is something maybe to be thinking about, starting some of those conversations, and who could help with that. So we'll have a look at that in the plan too. And so the last question in this section then is looking at how able you feel to continue with the current level of caring that you're doing. And we've got a scale here from 1 to 5, going from number 1 is not very able to continue to 5 very able to continue. And I'm just wondering where you feel you might be on that scale of 1 to 5 in terms of continuing with the current care.
Well, I would, if I had to do it, I would do it. I would carry on. But I suppose thinking that his condition is going to get worse, I can't carry on forever.
No.
I would say it's probably about a 2 at the moment.
Okay. Thank you for that. And I think we've got some areas here that we can look at in the plan next. So I'm just adding up the score there on about a 12. But I can see from us looking at this that there are some areas where you're feeling quite high need around having a break, and that would, and if we can bring in friends and family, that might also help with being able to talk to somebody about worries and concerns, and also thinking about some information for you, not overwhelming information, but a bit more information of what's happening and what to expect in the near future, and also looking to do some preparation around having some carers come in maybe to help with some of the personal care, and obviously that's something that would need to be discussed with George as well, and worked with at a pace that you're both comfortable with. So what we're going to do now then is we're just going to think about the areas of need that were there, and make our plan of what might happen next. Okay? So there was definitely a need there around information. Would you agree that's a priority at the moment?
Yeah, I suppose so. I think I need to have a bit more of an idea about what's going to happen and how quickly things might happen.
Yeah, absolutely. Okay, so we'll put that on our plan, and I think when we've finished this, we'll have a chat about things, and I can signpost you to some information such as our MND toolkit, and we'll also think about other people that might be useful to talk to about that. Okay. So the other thing that you circled as quite high there was around having some support, and that is for yourself in terms of being able to talk about worries and concerns, but also having a break. Yeah, so maybe we could have a look at how that could be broached with friends and family in the first instance, and we can also have a look to see where there might be support from outside as well, which could come in to support having a break, sitting services, or in your community, people that provide supports around that. Okay, and we'll sign off this, and we'll look, because you've got some high needs there that we want to discuss and do actions for. We'll create a next review together, if that's okay, which will be quite soon. I think because you've got some medium and high need there that we've identified, I think within the next month I'd like us to be revisiting and seeing if things have moved forward with the signposting and with looking at the additional support that could come in. Does that sound reasonable?
That sounds fine.
Okay, so we'll make that within the next month, so that we can have that follow-up conversation. Okay.
The next part of the
Okay, great. So I mentioned before the support and information toolkit that would help both the service provider and the families in need. The toolkit provides further information on support available for carers in each CAT item. Ideally, carers are informed at registration with the association about the toolkit and provided with a fridge magnet that has the website link on. I'll show you what it looks like, the fridge magnet. This is what we did here. We posted that to the 200 families that we had on our books at the time. And this is what they see on the website of the toolkit. And when they click on each of those boxes, it shows them like understanding MND, what's there, and so on. So we've taken few screenshots from our website. So this is for basically, you can see there the different boxes, understanding MND, support for providing personal and general domestic care, emotional and spiritual care. And then if you click on understanding MND, there's always like a story to, again, make carers understand people in their situations, why they've looked at that information, because sometimes they think, I mean, obviously not with understanding MND, but the other items, they might say, oh, that doesn't affect me. But when they read people's stories, they will understand that. You see at the bottom of that screenshot, it's got the links to so many resources, whether it's state, national, or international. Managing your feelings and worries, again, it directs them to, also carers help and carer gateway, and so it's more like a one-stop shop for MND family carers, where all the resources that they need, it's all there for them to tap into. And that means they can improve their knowledge, get the information they want without having to call you for that. So when you come and visit the patient and they still have, or you want to talk to them about their needs, they don't need to bring up things that they've already sought help for themselves. They just leave the really, really, I suppose, sticky stuff to discuss with you. So, the links of resources basically changes from each, CAT item. We've updated the ones we've done here this I think it was the end of last year. I know in Victoria, Andrea is, that's part of the project. So really the next phase is to get that toolkit on every MND website. There is funding to help with that. So the team leaders, I'll discuss that with you. So Andrea, I think she's got something pretty close to finishing. Andrew Collins in New South Wales, he's also doing something about it, but I'm not sure what's the situation with South Australia and Queensland, but we can talk about this later. So some of the feedback we got from the MND carers who are connected to the toolkit, I feel like it will be of great benefit not to wordy and doesn't go into minute detail, that has follow-up sites for those who need or would like more detail, as well as sites for practical help. I like how it has both details of the disease, MND, and ways to help and support those with it, e.g. OT equipment, NDIS, ACAT, hospital teams, and then goes on to support for the carer. I found the practical examples of people seeking solutions to their situation helpful. It gave me a feeling of not being alone. I feel it will be a valuable tool to have, and being online, it's available 24 hours a day, as well as being able to be updated and amended as needed. So what are the benefits of using such a systematic but shorter and crisp approach to doing that for the care recipient, for the practitioner, and for the organization? So for the carers, we've already mentioned, it legitimizes their needs, and the process of assessment becomes visible. They matter, therefore we need to assess their needs in a visible way now. Engages carers in the assessment process and tailors support to their individual needs. Encourages carers to be proactive and resourceful, and this is really so important. And this is where we need to get to in this process. Benefits for the care recipient: a carer who's supported is more likely to be able to support the person they care for. It reassures the care recipient that their carer is also being supported. It may help facilitate the care recipient's preferred place of care and death. And that's certainly what happened in the randomized control trial we did. Because of that conversation that was happening, the care recipient knew much better what is the preferred place of care and death for their loved ones than the control group. Benefits for the practitioner: it's a comprehensive and timely assessment. Again, it sort of helps with avoiding a crisis management. On the long term, it is time saving because it's really tailored and it's quick to do as you do have more practice at it. Helps with expectation management and provides clear documentation and makes work visible. For the organization, I mean, when we did with Silver Chain, that was a requirement for their auditing processes, that they needed to show that they have a focus on family carers. I don't think all organizations would have that, but it provides a clear record of activity in relation to carer support, useful for auditing or commissioning purposes, whenever that may be. Sometimes we may be applying for a grant and they may be asking, oh, have you got any strategies on how you help your family carers? And that could be one if you are able to get it into routine practice. Demonstrate the organization's commitment towards assessing the support needs for carers. So Bowen Health have been, to my knowledge, the first to actually implement this assessment experience, but using a similar tool before that didn't have a scoring system called the Carer Support Needs Assessment tool. So when I asked the team leader how was it going, so in terms of acceptability, she felt it was acceptable to carers and staff. The most common carer feedback they got: it was an easy to use form, and it was fantastic that we were also assessing their needs. In terms of adoption, there was an initial reluctance that was overcome. It's now well integrated into our daily practice and adopted by all members of the multidisciplinary team. Feasibility integration within our setting was relatively simple because it was such a simple tool to use with minimal burden to either staff or carers. And we had in the last week's session 2 nurses from Bowen Health, or social workers, and they said that they're still doing it now. How many years it's since they've decided to embed it into routine practice. Coverage: the assessment is offered to all carers of palliative care patients. We now have, obviously, the Bowen Health, it was the palliative community, palliative care in the community. So the assessment is offered to all carers of palliative care patients. We now have 84% compliance with our procedure. And pleasingly, when needs are identified, a plan addressing needs is formulated with the carer and documented 100% of the time. In terms of sustainability, strategies are in place to ensure use is part of our normal practice with carers. The forms are included in our admission packs, the documentation in our notes pro forma to ensure that the team are being prompted to address carer needs and to document accordingly. And so when they registered a carer, they used to give them a bookmark that had the toolkit website link. So we got the idea from there, but we thought a fridge magnet is probably, you know, in their face more all the time rather than a bookmark. So the developers of the tool, the CESNAT, looked at what are the barriers for organizational change, and they've come up with 10 recommendations, because even in the UK they felt that the service providers were not taking it up in routine practice. And they had a quote down there: unless we support the carers aren't going to support the patients, and then we're all going to be struggling. And may I add, there'll be more you know, pressure on the MND associations or the health services to actually cope with that. So the 10 organization barriers that need to be overcome: consistent identification of carers within the care setting. Again, you know, a spouse would not identify themselves as a carer, but you know very well that, you know, they are the primary carer of their husband. So they just need, you know, this explanation. Demographic and contextual data on who the carer is and their situation. So you almost need to have like a database for the carers themselves. A protocol for assessing carers and responding to the assessment. So we've showed you one of the protocols now. A recording system for carer information separate from the patient data. A process for training service providers about carer assessment and support. And that's exactly what this project is about from this, you know, international document. Available time and workload capacity for carer assessment and support. I mean, that's something, again, that each service will need to see how to make sure that, you know, the assessment can be done with the carers. Support from senior managers for carer assessment and support. Wherever we went, there was great support from senior managers, but that's not enough. It's people like you on the ground that really need to be supportive of this and make sure it happens. We need to have role models and champions for carer assessment and support. And I guess, you know, with you being interested to be part of this, you are the champion for the carer assessment in your organizations. Pathways for communication about carer assessment and support, again, in your multidisciplinary teams, if you're able to, you know, embed this somehow. And need procedures for monitoring and auditing processes and outcomes for carer assessment and support, and that comes towards the end, really. So in the UK, the National Voices report on the person-centered care touched on so many of those values that, you know, we've been talking about. We need to make person-centered and community-based approaches part of normal business, and this is what MND associations are about. They are a community-based approach. Too often we are ignored by, you know, the health departments everywhere, and I've been really sort of being quite clear about how community-based organizations are enablers in this whole process, and they need to be taken seriously and resolved seriously. To support system developed, person-centered, community-focused interventions. To give the opportunity for family carers and their loved ones to take an active role in their care. To be treated in a way that recognizes and respects the outcomes that matter most to them. And you'll only know what matters most to them if you actually have that conversation with them. But unfortunately, in a lot of organizations, we measure things, we measure outcomes that are not really things that patients and families really need. So we need to make the important measurable rather than the measurable important. We have so many things that gets measured in our hospital, in our clinic, that don't end up anywhere. But we think that it's just too hard to start measuring what's important. And I know one of the clinicians said to me when I asked him, does he ever ask the carer how you're doing? And he said, well, that's too difficult because I don't have time, because I know the carer, they're going to say, this is exactly, you know, the Pandora's box, but I don't have time for this, therefore I don't ask this question, which is a real shame, because if the carer is looked after, then maybe the patient doesn't need to come and see that clinician that often. So interventions that directly supporting the carers need to be integrated into existing practice. It just won't work if they are working alongside existing practice, because they will disappear. So we've come to the end of it before we have a discussion, but let me just acknowledge FightMND for financially supporting this project. Of course, the MND associations for supporting it, the MND and other clinics, and of course, the UK developers of the CAT, Professor Mary O'Brien and Dr. Katherine Knighting.